Net case is a female patient in her 70s with a colonic laterally spreading tumor, granular mixed type. The lesion locates in the Shanding colon, which is 30 millimeters in size. The colonic ESD will be performed by Hironori Yamamoto Sensen.
Hi, good afternoon, everybody.
Good afternoon.
Okay, I want to explain the pocket creation method of ESD. But first of all, I want to introduce my team, Dr. Hirosawa, Dr. Fukuda, and Toyonaga, and Dr. Yahagi, and Dr. Ohata working together. Okay, anyway, this is the lesion. And I am currently using the Fujifilm therapeutic colonoscope. This is a special colonoscope for ESD. The outer diameter of this scope is only 9.8 millimeter. That is the same as the upper endoscope. So very slim. And the accessory channel is 3.2 millimeter. And the cap, the hood I attached is the new ST hood that is 33 GR, DH33GR. This is the brand new one, not released yet, just approved, and it will be released after the Dr. Inoue's endoscopy meeting in May, the end of May. Anyway, so this is the lesion, and I will show the orientation. This is the appendix orifice, and the lesion is located in the ascending colon. And I selected the patient's position to be left lateral because the approaching angle becomes tangential here. And then I select the opening, the entrance of the pocket. This is the lesion, lateral side. And I check the all around the lesion. So the biggest concern is this nodule. So I want to dissect under the nodule very carefully. So I decided to create a pocket from here. So entrance of the pocket should be around here. So I just put a marking. So it's about one centimeter from the edge of the lesion. So this is the soft coagulation current. And to just one mark. And then let's make injection. I made the mark because sometimes after the injection, it becomes unclear where the best approaching line, because even this kind of vertical approach area could become flat after the injection.
You mean this is not the mark for the anal side, but for the entrance point?
Entrance point, yes. So inject. So this is the sodium hyaluronate solution, and inject about 1.5 to 2 milliliters per each puncture. Stop. And then I extend just a moment, just the base of the protrusion here. Yes. Yes, inject. Okay.
Now, Dr. Yamamoto is lifting up the mucosal flap using limb of the transparent hood a little bit. Then he can keep the safe dissection plane during the submucosal dissection. I think this is one of the great merit of pocket creation method. Even with the complicated structure within the right side colon, he can select the right dissection plane at any time by using the tip of the transparent hood.
Okay. Then and in this situation, this lesion is rather under the underside of the gravity. So in this case, maybe I can use the underwater technique. Okay. Can you increase the effect to 4? Now 3.7. Swift coag, swift coag 4. Okay, good.
So the voltage is coming up to 1.3 kilovolts
Okay.
from 1.2.
Yeah, probably in case of using normal saline, also for the water irrigation from the endoscope, we can use a much lower setting of the swift coag. Because you are using distilled water for the water irrigation from the endoscope, it requires a little bit higher electric current.
But this is not very high. Do you use Swift Coag, Dr. Yahagi?
Yes,
And
I
what is
usually
the
use swift coag, probably around 3.5.
3.5?
Yeah.
Actually, to control the movement as if the respiratory movement is large, pocket creation method is the greatest advantage.
Yes.
So I guess in Dr. Yahagi's case, in the morning, if you apply pocket technique, you could cancel the
Now
respiratory
can I use
movement.
the
Yeah,
water
I
jet
agree with you.
through the then again in the water technique. As I had shown you, I made the procedure difficult because of the hematoma. In such case, I create a pocket to the both sides of the hematoma. Then you know where you should cut. So that is a similar strategy to the fibrosis. And whatever difficulty is there, you have to know the dissection plane. In order to estimate the dissection plane, creation of the pocket to the both sides of the fibrosis or hematoma helps. So now I could pass the hematoma. So in this way, even if some kind of difficulty you made yourself, you have to overcome that difficulty. So it's of course it's better not to make hematoma. So the initial cutting shouldn't be too deep because the initial mucosal incision is blind fashion, and just only mucosal incision, and then you can see the blood vessel. Then you can selectively dissect the submucosal tissue, and you can avoid cutting the blood vessel. Okay.
So Yamamoto Sensei,
Yes.
so your advice is if at the initial mucosal incision you encounter moderate bleeding and you get staining,
Yes.
better to change your approach and dissect lateral to the area rather than persisting and having more problems.
Yes, that's right. That's right. So that made the opening of the pocket a little bit wider than I wanted. So the endoscopic control is a little bit unstable because of the wide opening of the pocket. But still, I think it's better to choose other route to avoid the difficulty. And this is the blood vessel. So whenever you find the blood vessel, you have to isolate the blood vessel. Just dissect close to the blood vessel, and then you can cut the submucosal tissue uh, around the blood vessel. Then after isolation, then you can change to the spray coagulation with very limited. This is 0.7 by bio 3, and then you can coagulate it. After coagulate, then you can cut. But that time, don't cut here. Then you make bleeding again. So cut here.
It means a coagulated area point.
Yeah, you have to leave the coagulated point like this. Otherwise, you will make the bleeding again. Yeah, because of the wide opening of the pocket effect is not very good. Anyway, how deep should I go? Let's see. This is the this is not that big. The lesion is not that big.
Injection is already come to the
No,
oral
come to
side,
the other side.
so almost you have passed
Yeah, I
the
have
lesion.
already passed the center of the lesion. So suck the air as much as possible. By sucking the air, you can make the approaching angle tangential. Okay, now this is the injection to the oral side. This is the retroflex view. Okay, I will show you the progress later soon. Injecting with retroflex. Now I am already opening the pocket. Okay, stop. And you have to be careful. This is the muscle fold. Don't cut this one. This whitish tissue is the muscle fold. So you can cut here to, to separate the muscle fold, but don't cut here. This is the muscle. Okay, so
So I guess visualizing submucosal layer by blue color of indigo carmine is very helpful to identify the true dissection plane. And we can select the true dissection plane, avoid touching whitish part.
yes,
Yeah, we can see muscle layer on the right side, that is whitish area.
you have to assume the whitish stripe is the muscle layer all the time, even if that is separated by injection. Even if the injection is made to the muscle layer and sometimes the fiber is separated, then you will be easily fooled by the appearance. But don't assume that is the submucosal tissue. Always whitish stripe is the muscle layer.
Yamamoto sensei,
Yes?
how do we know the end of the pocket?
Oh, that's a good question. I measure the depth of the pocket and compare the measurement outside of the pocket, the length of the tumor, and the color of the mucosa changes by the ischemic change after dissection under the tumor. So, and the other thing is the injection made from the inside of the pocket goes to beyond the tumor, then that means the pocket is deep enough. Those information helps.
And how much do you dissect the submucosal tissue from the entry point when you conduct the pocket creation method?
What do you mean?
It's about 80% of all the submucosal layer below the lesion, or about 60% or less. I mean the percentage of the submucosal dissection from the single entry point.
Oh, I see. About probably about 80%. I tried. Okay, then now I can open again. So the let's inject again. A little bit burning to the normal mucosa, but this is not a big issue. So lateral margin is not that important, but vertical margin is more important. And of course, as long as I see uh, the lateral margin of the lesion, I don't cut into the tumor. Okay?
Hironori,
Yes?
it is no more pocket, it is more or less a tunnel now, no?
Yeah, now, yeah, it's similar to toenail. Yes, right.
So what is now the rule of, because you don't do a complete pocket and then you cut the edge. You always do a small pocket and then you do a tunnel. This is difficult
I
to understand for me.
I made a pocket. Then during the opening process of the pocket, I just left a little bit of tissue. So
Yes.
that this is just a submucosal tissue. So that looks like a toenail, but my concept is still the pocket. Pocket is wider than a toenail. Toenail is a very narrow, straight way from the entry to the outlet. So I still think this is pocket and leaving a little bit of tissue.
And
I
as
think.
Dr.
Yeah.
Yamamoto already mentioned, leaving small amount of tissue on the upper side is quite effective. In case
Okay.
of dissecting that small amount of tissue on the upper side, all the dissected area coming down to the lower side according to the gravity, then following mucosal incision on the lower side will become very difficult. This is a really clever way to do a smooth procedure.
Okay. Then let's dissect. Maybe it's already easier to go from the oral side.
And when will you complete the circumferential mucosal incision? I think it's time to
Soon.
complete the circumferential mucosal incision because you already widely opened the submucosal space.
Yeah, but I want to dissect a little bit more here. This part, the pocket was not deep enough,
Hmm.
so I have too much too much submucosal tissue leaving here.
And Dr. Yamamoto is lifting up the dissected area with transparent hood still now using up angle of the endoscope. Then he can keep the safe condition to do safe submucosal dissection.
Okay, from this side. Okay. So this kind of small blood vessel, you said, slowly cut with swift
Uh,
coag.
I think swift coag is
Okay.
strong enough to abrade tiny blood vessels. If we go slowly, we can dissect the tissue without having bleeding.
Yeah, here is the blood vessel, but as you said, slowly. Okay, that's the blood vessel.
I think speed of dissection is very important for us. Even with
Okay.
the same electric current setting, if we go faster, it sometimes goes bleeding. Therefore, if we find the tiny blood vessels within the submucosal layer, we should go slowly as far as possible. Then we can avoid bleeding during submucosal dissection. And
Okay.
of course,
Yeah.
if there is much thicker blood vessel, we should dissect surrounding tissue before cutting the main trunk of the thick blood vessel. And if it is necessary, we can switch to the spray coag or post coag to coagulate the thick blood vessel. But
Okay.
most of the tiny blood vessel can be easily
Now
coagulated by just using
it's better
swift coag.
to approach from this side is easier. So now I'm approaching from the front side. Front side means the anal side, straightforward view. I cut the mucosa and dissecting the submucosa. to the pocket side. Okay. A little bit, the pocket was a little bit narrow, so I have to dissect more here.
Yamamoto Sensei,
Yes?
actually there are only 3 minutes left with this session, so can you give us some tips about this creating pocket creating method during this case?
Okay. The pocket creation method is useful to stabilize and select the dissection plane, but uh, it is sometimes tricky to to identify the muscle layer, and you have to identify the muscle layer, uh, and otherwise you have to have a good orientation. Otherwise, the muscle layer is not straight, so you could cut the muscle. So you have to have a good orientation of the how the muscle is running. For example, this one, this is a fold, muscle fold. So you shouldn't cut this muscle fold. So you have to know that this kind of muscle fold exists. So you have to have a good orientation. And this is the blood vessel, so I leave the blood vessel, and from here, I cut on the fold.
So, Yamamoto Sensei,
Yes?
can you just tell us the strategy that you'll have for the remaining dissection, how you will complete it?
Okay, I just left a little mucosa here, so I will dissect to uh, the same width as I made the mucosal incision, and then finally I cut the mucosa all around the lesion and finish the procedure. So my principle is always try to dissect the area where the mucosal incision is made. So it is better for recovery. So this is a big blood vessel, so you have to be careful. So big blood vessel, it's better to leave it. So this kind of small branch, just using swift coag, you can cut. But don't try that for this big vessel. So this kind of big vessel, it's better to use the coagulation forceps.
Or otherwise, we can use a lower setting of forced coag or spray coag to coagulate vein front.
This was a blood vessel.
I'm sorry talking.
No, it's okay. It was.
So very unfortunately, it's time to close up the session. So thank you very much for all the performers, nurses, and everyone for achieving these great performances. Thank you very much.
Thank you.